Good morning, review. Let me thank, first of all, let me thank the organized committee, and especially Professor Bellantone and Professor Lombardi, who invited me to take part, to attend to this wonderful, well-organized Congress. So it's a great pleasure for me to introduce Gregory Randolph. He doesn't need any presentation. He's a professor of surgery from Harvard Medical School, who will talk about the radiographic prediction of invasive disease, the R score. Please.
Thank you. Thank you. Appreciate it. I want to talk about trying to predict what's going to happen at surgery before it happens. I think this is easy to do with imaging, and I think it empowers the surgeon to have more detailed discussion with the patient and to be prepared for the surgical event. Again, I want to thank the steering committee and Dr. Bellantone especially for his leadership in this wonderful meeting. The friendship really, as you said, in this meeting is remarkable, and it infiltrates from the steering committee all the way down to, frankly, all of the panels, or just really collaborative and wonderful group of friends. So the R score. So this nerve is a nerve that you can easily see. I show some of these pictures that's common to surgeons, but some of the endocrinologists may not see exactly that there is sometimes a little bit of blood in the field. This is a nerve, though, this is one of Ashok's slides. My slides are not so pink, but so this is a nerve, the left recurrent laryngeal nerve. In the left portion, it's entering the larynx. It's in the tracheoesophageal groove. This is a nerve that would be characteristic of like a Patriots linebacker, a very big, thick, broad male with a very thick cable-like nerve, very easy to identify, very hard to hurt. Oh, I think we've slipped some of the slides here. So, yeah. The problem is that if that nerve is injured, there is mortality consequences. This is big data analysis in the UK by Neil Tully. And really what this relates to is some of what Megan Haymart has also shown, that in an elderly population, these innocuous, small, little local regional complications are not so small. They have major impact, mainly aspiration and pneumonitis, and this has long-term mortality impact on patients. But I think there are some reasons to have hope if we just stop and think, a pilot before he takes off on his plane, make sure the gauges are working, make sure there's fuel in the tank. So we as surgeons should also kind of kick the tires once or two before we go into the operating room, not just shoot from the hip. We'll find out when we get in there what's going on. And so this is a Hürthle cell carcinoma that is invading the nerve. It shows it's a miserable, nauseating kind of problem for patients. It's a beautiful picture of a nerve infiltrated with Hürthle cell carcinoma. And so my practice is enriched in kind of neural problems. And so we took a group of 73 invaded nerves. That is nerves that are found to be grossly invaded at surgery, where for complete tumor resection, the nerve would have to be resected. And so we looked at this group. This was about 40% men, about 60% women, mainly papillary carcinoma. We resected the nerves in this group about 73% of the time. Tumor was intentionally left on the nerve in about 25% of patients. This is a sick group of patients. They have other problems going on with their tumors, not just at the nerve, sometimes just at the nerve, but not often just at the nerve. So RAI was frequently administered. XRT was frequently in a third of patients administered, and some form of chemotherapy in about 25% of patients. I just wanted to share with you some of the details and then some of the radiographic kind of details that we got out of this group of patients, which helped us formulate our initial version of this R score, this predictive index preoperatively assessed to determine risk of neural invasion. So this is, interestingly, the right nerve affected more than the left nerve. This relates to some variation in complexity of the three-dimensional anatomy of the right paratracheal region as compared to the left. The nerve was resected in 71%. A variety of co-invaded structures, most commonly strap muscles, but including everything from parathyroid to esophagus. Vocal cord paralysis was present in this group of patients with gross nerve invasion in only 45%. So when the nerve is out preoperatively, that's clearly a bad thing, but it does not prove that the nerve isn't invaded. So we know now that malignant infiltration is something that happens gradually over perhaps weeks, months, perhaps years. The nerve withstands functionally the invasive front for a long, long period of time. Only half of invaded nerves that require resection are paralyzed preoperatively. This is the surgical procedures that were done on those patients. And interestingly, this is the three groups of EMG data at the beginning, maximum, and at the end of surgery for these groups. And so no invasion is the first panel, invaded but with normal vocal cord function preoperatively the second panel, and invaded but with vocal cord paralysis on the final panel, which tells you that the EMG characteristics of these nerves, if there was normal function preoperatively, is the same as a normal nerve. And even when there is preoperative vocal cord paralysis, there are many fibers that are still going to the larynx and connected up. And so you still have EMG stimulability of the nerve, even if there's vocal cord paralysis in the setting. And that's why often when you resect a nerve that's invaded, even if they have preoperative vocal cord paralysis, their voice gets worse and their swallowing gets worse because there are other fibers below the clinical limit of gross motor function as detected by fiber optic exam. So now we looked at a couple of things all within this, and again, I apologize for the preliminary nature of some of this data. This is all within that invaded group. Let's just look at some of the natural history factors of this invaded group. So is there a difference in recurrence-free survival in patients based on age? There is. So within this invaded group, you recur more commonly if you're over 55. You have a different pattern of recurrence, worse pattern of recurrence depending on the subtype of tumor, the grade of the tumor within this invaded group. That makes sense. Interestingly, XRT made a difference in recurrence-free survival in these patients, external beam XRT. But there were many things that did not make a difference. Whether we resected the nerve or not didn't make any difference in terms of recurrence-free survival. So the AJCC that includes RLN with trachea, esophagus, making a tumor a 4A, it should be back to 3B with strap muscles. There is no recurrence significance to nerve resection in the setting of invasion. Similarly, kind of in an analogous way, leaving some tumor on the nerve, no difference in recurrence-free survival. And whether radioactive iodine was given or not to these patients with recurrent laryngeal nerve invasion, no difference. Different than external beam, a lesser treatment. And whether chemotherapy even was given to these patients. So this idea of, well, we won't radiate them, we'll wait for the lenvatinib threshold to be passed, doesn't look like it's a really valid concept, at least as it relates to the neck. And no difference men versus women, no difference left versus right. So basically, nerve resection really didn't make a difference in terms of survival. So the AJCC categorization should really be corrected to downgrade RLN invasion at least equivalent, if not less, than strap muscle invasion. So with this subgroup of patients, we extracted some axial scanning information to see, can we predict these patients preoperatively? And the answer is we know we can. We're just applying some numbers because we do this clinically. This is a case you look at and say, I mean, I like hard-boiled eggs, but I don't know why. It's a very good, easy way to think of it. Is the yellow of the egg, that is the invasive, potentially invasive cancer, solidly within the white of the egg, that is the lobe? And if that's the case, as in here, the risk of nerve invasion is 0. If you have a case here where the nerve is kind of somehow, some of that yellow is somehow abutting up against the airway, maybe starting to move towards the tracheoesophageal groove, we know where the laryngeal entry point is. We can't see the nerve on axial CT scanning, but we can sure see the cricoid cartilage. We know where that nerve is going to enter. If the tumor starts to approach that area, we know there is an increasing risk here. If it's a 6 centimeter mass, that's quite increased. If it's a 1 centimeter mass that's kind of approaching it, we maybe say 30–40% risk. And in a case like this, it's a guarantee. Whether the cord is moving or not, that nerve is invaded. We know that. I tell that to my patients. So really this R-score is some preliminary data analysis to get some numbers onto this, to get some meat on these bones, to try and figure out how do we get a number that we can easily apply so that when I go into my fellow comes out of my room of a new patient with papillary carcinoma, I'll ask 2 things. What's the nodal map and what's the R-score? In other words, extract all the information we can from our imaging. So here are some of the parameters that on multivariate analysis became important to include in the score, and that is, interestingly, primary disease is more polite than recurrent disease. Kind of makes sense, right? Bigger tumors worse than smaller tumors. That makes sense, especially this 4 centimeter cutoff. And then the data, that is it abutting the tracheoesophageal groove? Is the yellow of the egg extending significantly outside of the white of the egg, specifically in the tracheoesophageal groove at the base of the cricoid cartilage? That really, all of these parameters relate to that. The last one is another non-radiographic parameter that is important to include. As I've already mentioned, if a vocal cord paralysis is present, you want to really upgrade your impression of invasion if there's an ipsilateral vocal cord paralysis. And so with that in mind, this is the first draft of our R-score, you can, by a point system, determine increasing risk of vocal cord recurrent laryngeal nerve invasion with a graded increasing risk of vocal cord paralysis. And this helps because then the endocrinologist, when I call them on the phone and said, oh, I had to take the nerve, they think, oh, well, he just bumped into it and, the tumor was kind of close. If you say, I kind of knew about this beforehand, the patient also appreciates knowing what exactly are you going to do? Are you going to likely take this nerve? You can paint out, you say, it isn't perfect. We can't exactly predict, but we can, say this house is on fire. You're going to get hurt if you go in there, and we're going to go in there. And this also has very significant impact on me calling up Mike Tuttle or Peter Kopp and saying, there are no nodules on the other side. It's a young person. It's only a 3 centimeter mass. If I can get gross disease out, would you be willing to radioablate the other lobe? Because this patient says a trach is unacceptable to them. I can talk about that if I know the nerve is going to be coming based on the R-score. So it allows better, more acute pre-op planning, and it allows us to dial in patient and our endocrinology colleagues' expectations as to what the surgery that will be needed will actually be able to do. That's the R-score. I work with a very big group of individuals in the Wellman lab and a whole variety of surgical and clinical colleagues that I thank for doing all of their work with me. I want to invite you to Boston in November for our Harvard surgical course in 2020 in November, and of course to Boston 2021 for World Congress 4.0. Thank you for your attention.
Thank you. Any question from the audience? No. Just? Okay.
Sorry, Greg. What is Greg? Greg, for a surgeon, is always difficult to decide to cut the nerve. So usually we try to preserve the nerve also if we look a small invasion. So which is, if there is a best indication to cut the nerve? Because if we can wait something from the chemotherapy or radioiodine therapy, we prefer also to leave a small part of tumors at the
It's
thyroid.
exactly as you say, that the answer to that question is it depends on exactly what patient we're talking about. So if you have a 20-year-old who has fairly substantial nodal disease that you know is going to buy her 150 millicuries, I have no problem leaving a 6 millimeter plaque of tumor because I've never needed to go back for that because she's going to have tremendous radioactive iodine uptake. If I have a 73-year-old male with an invasive medullary carcinoma, I don't have any of that safety net. And so I have to be much more aggressive with my scalpel to get the cancer out because I don't have anything else to rely on except perhaps external beam. So this is part of some of this information is that external beam really is, as a surgeon, it's gratifying how much cleanup external beam radiation can provide, in the neck. So the answer is it's customized, and radioactive iodine avidity, expectation of other treatments that you have to clean up what you have left is a very individualized decision.
Please.
Great talk. Thank you very much for all that data. Can I ask you, you give the impression that for every single thyroid cancer you do a CT scan with contrast.
I sure do.
You do?
I sure do.
So that is obviously something that's actually quite controversial as well. So can you just give us the rationale as to why a T1, which is the egg yolk in the middle of that, you would do a CT scan? Thank you.
So the ATA guidelines have swung back in part because of some of our radicality of getting axial imaging has skewed a little bit towards, so the ATA recommends that in the setting of bulky nodal disease or based on an ultrasound, a suggestion of an invasive primary, under those banners you're allowed to get a CT scan. I think CT scanning with contrast has gotten a bad rep. It delays radioactive iodine in a meaningless way. And if you need it for extent of surgery information, you should get it, and you should have a low threshold to do that. So bulky nodal disease is perfect. I don't ever want to miss the 1 centimeter node behind the right carotid innominate subclavian bifurcation, which I could easily get in a moment, but I have to know it's there. So when CAT scans show me nodes like that, you will become addicted to getting CAT scans. The axial information is also poignantly displayed in terms of that R-score invasion. Rocco?
Sorry, Greg. In your opinion, in the decision or if cutting or not the nerve, is important if the invasion is from thyroid or from lymph nodes? Because in my opinion, the lymph node invasion is more dangerous because radioiodine is less effective.
Yeah, I would agree with you that lymph node invasion is just as serious as primary invasion. The concern about primary invasion, though, is that if that invasive disease is left on that focus, you are leaving disease at the laryngeal portal. And intralaryngeal paraglottic space disease is one possibility. So it's always, I would rather go back on a nodal recurrence than I would a thyroid remnant recurrence for just that problem. The disease is cemented into the ligament to bury. It's not an independent nodal entity in space, floating in the fat of the paratracheal region. So I have to say I am a little bit more aggressive at the primary site than the nodal site, because you can always go back and clean the paratracheal region, but once it gets in the larynx, then that's really a major issue.
Thank you.
Mike?
So I very much appreciated what you said, because I think inherently many of us do this. But I think to introduce this idea of kind of looking at the scans more generally, both for us, the endocrinologists, for everyone involved to kind of give some guidance to patients preoperatively is very helpful. One concern, though, that I have with a potential conclusion from this is you talk about the idea of leaving some tissue behind, and at least based off your data, it doesn't seem to impact at least survival. What I'm concerned about is the difference between what you say, what you mean when you say leaving a little tissue behind, and how other surgeons may interpret that. I could imagine that in your practice, when you say you leave a little bit of tissue behind, you're really talking about a minimal, probably microscopic amount of tissue behind, whereas many surgeons may interpret that as, oh good, I can leave a big chunk of cancer right around the nerve, and I have a feeling that in that case, the outcomes may be very different. So how do you think you can teach that or interpret that so that surgeons understand we're still really talking about microscopic disease, not leaving kind of macroscopic cancer behind?
You know, there's a lot of details that go beyond the depth and timing of this presentation. So there are different patterns of invasion. The International Neural Monitoring Study Group just published a supplement in the laryngoscope recently looking at a categorization system of different types of invasion. There's invasion type A, which is where it's really perineural, but the structure of the nerve is not deformed, not swollen, not nodular, not ecchymotic. There's no intra-nerve tumor, and that's the sort of thing where you're dealing just with an epineurial kind of phenomena. It's attached to the nerve, but it's not structurally deforming the nerve. So there's all kind of different patterns of nerve invasion. So each case really has to be customized. I appreciate, though, that you're not leaving big chunks of tumor in the neck. I mean, the overarching, I think, parameter that every endocrinologist and surgeon in this room would say is that for at least papillary carcinoma, all gross disease needs to be excised. We need to be as good as we can to excise all gross disease at first surgery, if possible.